So thank you everyone for joining. I know it's a weekday and 7 p.m. post work, not easy time to be spending on a webinar, especially in the era when we have so many webinars going on almost practically every alternate day. It's an important occasion for us. We are launching today the India Hub for Common Sense Oncology. I think many of you who have joined here are aware of Common Sense Oncology Initiative, but just to give a brief, that the whole genesis behind Common Sense Oncology has been the cancer value crisis, which many of us have been facing over last few years in terms of the cost of the drugs going high. There's significant inequity in terms of access towards meaningful treatment. And at the same time, the approvals of the drug, which are coming practically every month, are based on very small difference in terms of outcomes, and the outcomes which really do not make much impact for patients. So this movement or this initiative was launched really to bring in the outcomes in terms of patient care which are meaningful for patients, ensuring that there is equity in access, the prices are fair, and everyone who's involved in oncology care, is working towards making the treatments and the care comprehensive and patient-centric. So that was a reason for Common Sense Oncology movement. There are three, main things which are happening under this initiative. One is to look at how we can make evidence generation, that is the randomized control trials and the other trials, addressing the outcomes and the way the trials are conducted, which are going to give treatments or the care options which are patient-centric. The second is evidence interpretation, which I think is equally important and much more relevant in our context, that anything which comes out in a high-impact journal, what does it mean for our patients? Does it really mean what is written in the abstract or in the article, whether the evidence is interpreted, which we are trying to do today, and we'll have people who will be discussing an important trial. And the last bit, which is equally important, is evidence communication. How we communicate to the patients better so that they can make more informed decisions. So that's another aspect, and where there is an entire project team working on how to understand what patients want and how the information can be communicated to them. A lot of things have happened over last 2 years since the CSO has been launched. But one important aspect, we realize that there are differences between regions, and therefore it's important to have hubs across different parts of the world to address local issues and bring the voice of the oncologists from that local area much more forward, so that the policymakers and the others in the field can hear them better. So as an attempt to that, we have started this India Hub, and we have the first webinar today. And I'll hand over to Aju for introducing these speakers and taking it forward. Thank you so much.
So anyway, today, welcome everybody. Today we have 4 distinguished faculty here to talk about the MATTERHORN trial. Dr. Gautam Sunny is from GCRI Ahmedabad. He will introduce the trial, and then Dr. Venkata will help us with interpreting the trial in a critical manner, followed by Dr. Sujana Priya from Hyderabad, who represents the radiation oncology colleagues, as well as Dr. Madhu Murali from RCC, who represents the surgical oncology. So we have all 3 significant specialists explaining or critiquing MATTERHORN trial, and Dr. Gautam will now introduce the study for us. Thank you, Gautam.
Thank you, sir. So a very good evening to one and all. So I'll be introducing the trial in short, within 5 minutes. I'll give you a brief gist of whatever was done in the trial and what were the outcomes that the authors had reported. So I do not have any disclosure. I've borrowed slides from Dr. Jan Jigian's and Dr. Klempner's ASCO 2025 presentations, and Dr. Albatran's ESMO GA 2025 slide set, and a single slide from clinical care options also. So moving forward, so the reason why MATTERHORN trial came into picture was because both gastric and esophageal cancers are highly prevalent, We know that perioperative FLOT improves survival, but many patients still experience disease recurrence. So for a stage 3 cancer, the 5-year OS is just about 50%, which is much lower than both colon and breast cancers. We also have data which shows that addition of anti-PD-1 therapy improves OS in the metastatic setting, which was from Checkmate 649, and improved DFS in the adjuvant setting, which was Checkmate 577. Perioperative FLOT has become a standard of care since AIO FLOT 4 trial was published in Lancet in 2019, and it is recommended and endorsed by all major guidelines because it was able to show a significant improvement in median OS compared to the triplet regime, which included anthracyclines. So what they tried to find out from Matterhorn was whether addition of immunotherapy led to any further improvement in survival. So this was a global phase 3 randomized double-blind placebo-controlled study. The study population included gastric and gastroesophageal junction adenocarcinoma, stage 2 to stage 4A, which was non-metastatic, and the patient should not have received any prior therapy. The ECOG performance status was 0 or 1. And this was a global trial which included patients from all over Asia, Europe, North and South America. The patients are also risk stratified based on their location, nodal status, and the PDL1 TAP score. They randomized about 948 patients after screening almost 1,250 patients. And then they were randomized into two arms. So there was 2 cycles of neoadjuvant FLOT with durvalumab or placebo given once in 4 weeks. This was followed by surgery within a period of 4 to 8 weeks. And this was again followed up by 2 more cycles of adjuvant FLOT with or without durvalumab. The other arm received placebo. And this was followed up by up to 10 cycles of durvalumab alone or placebo alone. Both of them were delivered once in 4 weeks. The primary endpoint that they tried to assess was event-free survival, and the secondary endpoints were overall survival and pathological CR. So this is a truly global trial, but then one thing which is striking is the lack of patients from Africa, India, and China, which is a major population subset. There were 19 countries and multiple centers which were included in the trial. It was a well randomized trial. Both arms were very well balanced, be it age or the geographic location or the site of the tumor, the primary tumor stage, or the type. The histological types were also very well balanced. Primary endpoint that they tried to look into was the event-free survival. So at 2 year, the event-free survival was the median event-free survival was 32.8 months in the placebo arm, while it was not reached in the FLOT arm. And this was the hazard ratio was 0.71. You can see that the curves nicely separated after the 1 year, and was the 2 year EFS was 59% in the placebo arm and 67% in the FLOT arm. Secondary endpoint of pathological CR was also significantly improved with addition of durvalumab. It was almost 2.7 times. There was a 12% difference in the pathological CR when durvalumab was added to FLOT backbone. The overall survival data is actually not mature. At the time of interim analysis, there is a significant improvement is noted, but then it is too soon to infer or make any solid conclusions based on this. So the median OS is 47.2 months with placebo, and it was not reached in the durvalumab arm, and the hazard ratio was 0.78. They also looked at event-free survival in patients who achieved an R0 resection. In this also, the data was reported as significant nature with a hazard ratio of 0.7. And the median DFS not reached in patients who achieved R0 resection. They are also done subgroup analysis, and in almost all subgroups, there is a consistent benefit seen with addition of durvalumab to FLOT. Only thing is, you can see that the confidence interval is going across one for lymph node negative patients, patients with a PDL1 tap of less than 1%, and diffuse histology subtype. But the others in the trial say that it is the patient subset is too low, and overall there is benefit with addition of durvalumab. So the outcome of the control arm is also significantly good. So in the classical AAIO FLOT4 trial, the median DFS was 30 months. In MATTERHORN trial, they reported a median EFS of 32.8 months. The control arm was also strong compared to the historical data which has been reported. And they also highlighted a major thing that the addition of durvalumab did not significantly affect the preoperative delivery of FLOT or the postoperative delivery of FLOT or the surgery. There has been no delay in surgery or none of the, there was no significant proportion of patients who became inoperable due to addition of FLOT. You can see that almost 97% completed either durvalumab or placebo, and 96% and 95% received all FLOT, and almost 91 to 92% went ahead with surgery. And of the patients who underwent surgery, also 92% in both arms had an R0 resection. And a comparative proportion of patients again went to start adjuvant treatment with chemo and with placebo, and a similar proportion of patients were able to complete the prescribed treatment. Safety wise, also, they don't report any additional or an increased adverse effects due to addition of durvalumab. The grade 3-4 events has been 60%, but they are balanced between both the arms. And they report that it is mainly because of FLOT related rather than due to durvalumab related. Even grade 3-4 immune mediated adverse events is also comparable between both the arms. And there has not been any, I mean, the adverse event leading to delay in surgery is also comparable between both the arms. There is no additional data to suggest increased adverse event due to the durvalumab being given. Patient-reported outcomes were not reported in the paper, but they have been presented in ESMO GA 2025 using two scores, which is the EURTC QLQ C30 and QLQ STO22 plus IL38. And the patient-reported outcomes have been reported as comparable between both arms. I'm not going into detail because they have not been published. And the authors conclude with also mention the limitations of the trial. One of the main limitations they mention is that diagnostic laparoscopy was not mandatory before randomization or inclusion into the trial. And there was no separate evaluation for the neoadjuvant part of the trial and the adjuvant part of the trial. So the separate benefit of contributions is not exactly clear. They have excluded the lack of Indian and Chinese patients in the trial is a major drawback. The overall survival data is not yet mature. And finally, this is actually an industry-sponsored trial with AstraZeneca being the chief sponsor who delivered both the durvalumab and the placebo. And in area where FLOT could not be locally sourced, the company only delivered FLOT also to the trial centers. So at the end, the authors concluded that additional durvalumab improved event-free survival in resectable gastric and gastroesophageal junction adenocarcinoma.
Thank you, Dr. Gautam. Over to
Yes.
Venkatapati for a discussion on the study.
Thank you, Dr. Gautam. That's quite an extensive summary of the trial. And thank you, Aju, for giving me this opportunity and to be part of the first CSO meeting. So let us critically appraise from the common sense perspective and place durvalumab in the perioperative gastric and GG cancer beyond the headlines, what we see in the medical journals and newspapers. So the first question that requires honest examination is whether it is a landmark trial or a launchpad trial. Because GJ, we know that the prognosis is uniformly poor, and will MATTERHORN be able to answer the weight we have been doing for so long, or merely it is a beginning of a more complex conversation of adding PD-1 and PD-L and L1 inhibitor to the chemotherapy backbone. So somehow at this point of time, although we do not have complete data, we should be able to translate these findings into practical wisdom, because patients will ask questions whether they can have this therapy or not at this point of time. So let's navigate beyond the statistical significance to clinical significance, and whether we could apply the current results to our real world patients. Let us see the bottom line upfront first. What MATTERHORN is, what it is not, and what are our challenges as of now. What MATTERHORN is a positive practice influencing trial because the EFS benefit is true. We have seen what Dr. Sunny has presented. The pathological complete response is almost doubled. and there is no surgical safety signals, which means almost all patients are able to complete planned surgery. What it is not practice changing result for all our population as of now, at least in India. Not only due to the non-inclusion of Indian and Chinese patients, but we also do not have overall survival data as of now. And regarding the PCR, whether the significance of PCR in gastric and GEJ, we don't know. Like in breast cancer and other cancers, where it is we consider as a surrogate marker for the long-term survival. In GEJ cancer, it is not as of now. And our challenge is to see and navigate which patients can be included for DFLOT and how to integrate it with the finances we have and resource conscious healthcare environment we have in majority of the places in India. Why MATTERHORN represents a sort of landmark of adding PD-1 and PD-L1 to chemo backbone, because the scientific design is robust. We have seen the amount of globe that is covered in this trial, except India and Chinese patients. It's a placebo control study. And the most important point is the chemo backbone is the standard of care. It's the modern FLOT chemotherapy. When we see the results, yes, EFS HR is 0.7 and pathological response are also meaningful. But when we see the patient-centric approach, although we don't have the complete quality of life results as of now, but there is no detriment of quality of life is what is the conclusion we have seen from the previous slides. But when we see the details that is residing in the devil, the overall survival is the question, because as of now, we do not have enough events in the MATTERHORN trial to suggest on whether there will be overall survival or not, because it is a hierarchical testing that was done, and it has hit the first primary endpoint EFS, and the hierarchical testing stops here. And after that, we should have enough events to know about OS. The attrition reality, if we see, even in real world, we know that delivering FLOT is not easy. I work in Tejpur, I work in Nagaland. Delivering FLOT has its own challenges. Some of the government schemes doesn't have has not integrated FLOT yet, and patient travel from far off places. It's not easy to get admitted. They have financial constraints. They have toxicity concerns. And even in the places where there are resources in well-established circumstances like clinical trials, we have seen that only 60% of patients are completing adjuvant FLOT after the surgery. And in this trial also, it is 60% and 50% of patients have completed durvalumab, which is half the patients. So when we come to the real world, can be much more difficult. And the most important point is the biomarker confusion. The biomarker they have used is the TAP score, tumor area positivity. We are not actually ready for that. What we are doing till now is CPS, combined positivity score. Our pathologists are regularly doing it. They are accustomed to it. But TAP is something that is paving in not only here in other clinical trials as well, but it requires a lot of training as well. Coming to the academic considerations, it is very significant cost in Indian setting. 14 cycles of durvalumab is something that need to be think twice. We need to think twice before counseling the patient, particularly when they are coming with the financial constraints and from the rural areas. And regarding the hierarchical testing, we have seen that the overall survival has not accrued enough events, and we cannot assume that OS will follow the same positivity trajectory as EFS, because in other trials of GEJ and esophageal trials, we have disappointments where there is initial EFS benefit has not translated into OS benefit. But the one good point about this trial is it has guarded the type 1 alpha from the type 1 alpha error by providing the hierarchical testing, so that we will not false positively have a OS benefit. When we see the Indian healthcare reality, delivery of FLOT itself is a challenge. And coming to the DFLOT, when we deliver DFLOT 14 cycles, we can have IRAEs. Managing IRAEs in periphery comes with a challenge, because whenever there are IRAEs, may it be a simple rash or as serious as myocarditis, which are rare, but if it happens, when they present to the concerned specialist, they should be aware of how to manage IRAs, which is not an easy thing. So they should be oncologist connect where they can suggest and discuss with the other specialists to deal with IRAs as well. And coming to the equity and access concerns, treatment allocation, as of now, if we start counseling deflot and if we accept EFS as a good endpoint and if we accept it as a standard of care, there will be two-tier system. And the patients who are receiving the current standard of care, that is flot followed by surgery, they will feel or they will perceive that they are receiving less effective care than deflot. So there will be two-tier system of deflot versus flot. So again, this will be a question of equity and access. When we see the opportunity cost analysis, when the government or the insurance or a family has to sponsor deflot for a patient, the total amount of benefit we are getting from deflot for one patient, it can fund optimal surgery in high volume center as well as chemotherapy for several others. So the distribution of the cost within the limited available resources will also make a major role in before we deciding on the deflot with the available data as of now. So the common sense principle is that if we can do a good surgery and deliver a effective chemotherapy, which is the current standard of care, with a incomplete data, we should not go for the intensified treatment protocols at a excessive cost. So how should we approach in the current clinical practice? If it is a high resource setting, in a fit young patient, high risk stage 3, who has all the resources, we can discuss the deflot, but we should, in the consent, we need to mention that it is only EFS benefit we have, and the patient might not live longer. We do not have data of the OS that whether he will live longer or not at this point of time need to be clearly discussed. In resource limited setting, ideally we should prioritize delivering flot effectively and completing R0 surgical resection. In all other populations, if we have a specific populations like MSI and DMMR, we may refer to clinical trials where neoadjuvant immunotherapy, if at all clinical trials are available. And this biomarker landscape, it is a area where we have to navigate among the confusion, because the TAP versus TPS dilemma is something we need to discuss. Because when we see the TAP is the proportion of tumor area expressing PDL1 out of all the entire tumor area. So the formula is the PDL1 positive tumor area. So in the previous CPS scoring, the pathologist used to count the number of cells. Here he has to eyeball the area and then calculate the area, which is very subjective. So the disadvantage of TAP score is it is more subjective, and it is very less familiar, and it requires structured training programs. One important aspect is the pathologist experience significantly impacts the scoring consistency. So unless the pathologist has seen a significant number of samples and is very much trained in reporting TAP, there can be significant errors. And when we see the concordance rates, because CPS is very much objective test, whereas TAP is like a subjective test, and there has been reports that there is a significant concordance, but we do not have solid evidence. It was suggested that TAP score greater than 5% and CPS greater than 1 demonstrates reasonable correlation, but it is very difficult to say. So when we discuss in the multidisciplinary clinic, what are the considerations? From the surgical aspect, the operative timing, the resectability assessment, and the perioperative morbidity remain unchanged, although we have added 14 cycles at the map, which is a good sign. Coming to the pathology, it is definitely a challenge we need to navigate through, and it requires, if we have to adapt, and if at all deflot has shown OS, TAP scoring requires a lot of training for the pathologist, particularly in the rural areas. And coming to the radiation oncology, still we have a time-tested class paradigm, and there will be discussions whether we have to give class versus flot or deflot this thing. So this is a question that need to be answered, and a conclusion has to be come in tumor board for that particular patient. And medical oncologist, the concerns we are discussing all applies to medical oncologist as such. In the tumor board, the main question comes is that whether based upon the EFS benefit without overall survival data, whether we can consider this as a new standard of care. As of now, maybe no. And TAP scoring discussions will definitely come in the tumor board. And the other question that comes is it ethical to offer costly treatment without a proven overall survival benefit? The one question that always comes is whether we should confuse the patient by discussing this deflot at this point of time, because obviously when we discuss a benefit of EFS versus OS, patient will not understand the terms of EFS and OS. The burden is on us to decide and suggest them ethically. When we see the economic impact, because we know the recent papers published on the economic impact of the conventional chemotherapy and targeted therapies, and with immunotherapy, it is 25 lakhs additional treatment in addition to the flot and surgery. And 50% of patients only able to complete adjuvant durvalumab, and the opportunity cost is 5:1, which means if I have a limited resource, for the funding one patient of deflot, I will be able to treat 5 patients with flot and surgery. And as of now, this is under review by several societies, including NCCN, ESMO, and Indian guidelines. I would definitely like to wait for ESMO guidelines, because ESMO uses MCBS scale, and obviously it takes good parameters into consideration before approval, which will be applicable to majority of settings of India as well. What should be our research priorities as far as the MATTERHORN is concerned? In the short term, we should wait for the overall survival maturation data, and biomarker validation should be done between TAP versus CPS scoring system. The medium-term goal should be to do the cost-effective analysis like MCBS analysis by ESMO. We should do our own analysis in India. And the quality of life beyond the treatment completion should also be assessed when we are adding 14 cycles of immunotherapy. In the long term, because this has given a positive signals in pathological complete response and EFS, whether we can combine immunotherapy in other settings and how we should actually navigate through adding immunotherapy to the current standard of chemotherapy, because in its dismally prognostic cancers is the thing. So the final verdict from my side is it's a launch pad for sure, but it's not at landing. So our thought should be good patient selection, transparent and informed consent about the data available, and our focus should be on delivering fundamental therapy very effectively. The flot and R0 resection wherever possible in high volume centers. We cannot let the perfect become the enemy of the good. Our pursuit of the best, maybe deflot, should not compromise the good, that is flot plus surgery for our patients. Thank you so much.
Thank you, Venkata. That was a terrific presentation. We have some time for discussion at the end after all of our speakers have completed their discussion. But now I'll allow Dr. Sujana Priya to provide a radiation oncology perspective into this question.
Yeah, I have a slightly different perspective, obviously. So please allow me to share my slides. And yeah, Pradeep, it was a very wonderful presentation. Yeah, give me one. So yeah, so Pradeep and Dr. Gautam have already given their perspectives. So I'll just again briefly, just briefly do a quick review about CSO checklist as to whether this is the right approach what we are following. So both the speakers have set the stage very nicely as to why the standard of care about the flot 4 versus durvalumab. So if you look at it since 2019, since 2019, flot 4 has already been established. So, but the background rationale as to why they started looking to establish a new trial is about the recurrence rates. So that again has come from the Prosecco retrospective analysis, which was done from 11 Italian centers. So based on that, so that is the rationale they have used, and they thought they'll combine and see if they can improve the relapse rates. So if you look at the inclusion criteria, it is not very restrictive, and it looks more or less inclusive. And at the same time, if you look at the endpoints, so most of as per the common sense CSO checklist, either there are two aspects of primary endpoints. Either any treatment, whatever you give, it has to make you live life longer, and it has to improve your quality of life. Those are the two principles based on which CSO has been, formed, I believe. So if you look at the primary endpoint, they have looked at the EFS, and secondary endpoints are OS and PCR. Fair enough. So now whether your endpoints are exactly the right endpoints, what you're looking at, and this kind of answers your question. So EFS as a surrogate for overall survival in G-junction tumors. So again, this is a well conducted meta-analysis, and if you look at the coefficient of determination R square, which is the statistical coefficient of determination, if you look at it, R square tells how one variable predicts another. Everybody knows that. So usually the threshold is around 0.65, but here it is around 0.75. Basically, in this case, it shows how well the logarithmic hazard ratio of event-free survival predicts the logarithmic hazard ratio of OS. Fair enough. This is a reasonable endpoint of this particular trial. And also they have done a robust sensitivity analysis, which again ranged from 0.76 to 0.89, which is quite robust. So now coming to the baseline demographic characters of the patients in this particular trial, if you clearly look at it, so more than 75-year-old patients, majority of the patients are between 50 to 75-year-old bracket. So if you look at more than 75-year number of patients, they're very quite underrepresented, rather, I would say. So what are we going to suggest that? I mean, leave alone at 75, an Indian patient who will come late, obviously everybody knows, it's very frail, and offering FLOT itself is a very risky proposition at that point, but adding immunotherapy to that in an Indian context is a little, again, you have to take it with a pinch of salt. And again, looking at the performance status, 75% of the patients are of good performance status, ECOG performance 0 to 1. And again, representation. They have very well stratified between Asian and non-Asian populations. Fair enough, good enough. And but the representation from Asia is only around close to 19%. So rest of it, most of the population, what we're looking at are well-informed, well-read Western population or non-Asian population. So now coming to the main part of it, the main event-free survival, what we were looking at. So the median follow-up is around 1.5 years, rather, I would say 31.5 months to be precise. Yeah, so that is what we are looking at. So if you look at the upper end of the confidence interval here, so 27.86 is the lower end of the CI, and upper end of the confidence interval has not reached. It's of course is common with studies with good outcomes or shorter follow-ups. But again, it reflects that the data is immature, like what Pradeep rightly pointed out, or long-term survivors. So these are the things we need to look at. But I mean, I'm kind of an old school. Whenever I try to look at the KM curves, the Kaplan-Meier curves, I usually like to see the censored data. Of course, they have clearly talked about sensitivity analysis, about how they have censored patients and how they have accounted for the dropouts. But usually I'm kind of old school, as I said. I would like to see the censored data in the parenthesis. But that's all right. That's not a big thing to comment about. So now again, if you look at it, OS is they have done a very robust statistical analysis. You all know about the alpha, alpha allocation, alpha spending, and all, which has been clearly described. But OS is very, very conservative after the first interim analysis, like what Sunny pointed out, very, very conservative. So right now it has not reached and is not significant. But at the same time, if you look at the pathological complete response, which has been again shown, almost 2.5 times more chance of having a pathological CR. And at the same time, at the same time, the pathological complete response, they have kind of used liberal based on the alpha spending. They were not very, very conservative because that is an easily attainable goal. Or they have allocated around 0.1% based on the alpha spending. So now they have the important considerations. Strong main pros of the trial is clear and explicit definition of all the endpoints, which is the most important thing to have. Clear methodology of futility analysis or interim analysis. They have clearly mentioned that because there is no point if you have a futile trial, there's no point in going beyond that. That has been clearly done. Alpha allocation and alpha spending, they were being conservative at some point, being liberal, especially being conservative with OS, and they were very liberal with PCR, like I mentioned. So sensitivity and censoring and sensitivity analysis, it's a check. There is no doubt about it. They've also analyzed, they've also accounted for the multiple testing, and subgroups have been clearly specified. There is no doubt about it. So why do we need this? Because multiple testings obviously have a very high risk of having false positive results. That has been clearly accounted for. So few points to ponder. So in the trial protocol, they've clearly mentioned about the HRQL, the health related QL. Yet to come, I believe. I was not aware that it's being presented in ESMO Berlin. Probably we'll have to wait for that. PROMs, yes, that is also yet to come, but I'm glad that they have been included in the trial, which is very important. Some trials usually don't consider about including PROMs in the trial protocol. Of course, like Pradeep rightly pointed out, he works in a center where he's rightly pointed out all the technical difficulties and real world scenarios. I work in Hyderabad. I might not face in a corporate center, but I got trained in a healthcare center, government healthcare center. I know the challenges the patients face. So whatever he has rightly put out, it's absolutely true. So whether it is applicable in Indian context right now, I think we still have to wait for the long-term data, and also financial toxicity is one thing. OS is not significant like we mentioned, but chronic toxicities. So majority of the time we tend to put our head into grade 3, grade 4 adverse events or grade 5 adverse events. But what is the chronic toxicity? What are the smaller things every day which is impacting your quality of life? That we are usually not aware of. We usually don't document that because we kind of say, okay, this is happening. Okay, fine. Get used to it. Those small, tiny things are not explicitly defined. If you look at the adverse event scale, any adverse event scale in this particular trial, the most common toxicity is what you must be knowing is diarrhea. It's very common thing, diarrhea you just take, but these are the things which needs to be addressed. It's almost 60% of the patients had diarrhea. Is it a normal diarrhea? Is it a chronic diarrhea? Is it a diarrhea because of colitis? We don't have an answer for that. And again, crossover. So whether crossover is mandated or funded, because I know this is a pharma sponsored trial, I know crossover has its own implications, but at an ethical level, if you see if a patient is progressing, what is the second line treatment? Is it the standard of care? These are the questions we have to ponder in our mind. So of course, we have completed our CSO checklist. Like we have, yes, the control arm, what is being started. The slot 4 is the standard of care. There is no doubt about it. They basically, the hypothesis generating is they wanted to look at improvement of EFS at 10 months, more than from 30 months to 10 months, 10 months more in the experiment lab. So based on that, they have calculated the sample size, which is a reasonably achievable target is what I would I believe. So substantial clinical benefit, that is what they were looking at, improvement in EFS for 10 more months. So are the patients in the trial clinically representative for the entire world? That is already we have discussed. It is not, probably not, because most of the GI cancers are more common in this part of the world. So right now it is completely not representative. The surrogate endpoint we have clearly discussed. EFS is a reasonable surrogate endpoint as to how they have derived for it. HRQL has been evaluated. Optimal post-progression therapy, that is still a question mark. What they were going to do, we have no idea about that. Correct me if I'm wrong. Overall survival, because of a very conservative estimate, they wanted the overall survival, which is the topmost notch of the endpoints what we are looking at. Because of the conservative estimate, we just have to wait for a little longer before we take a decision and implement in the clinic. So yes, all the patients have been followed up to assess the survival. But now coming to the radiation oncology perspective, yes, CROSS has been, after SOPEC got published, everybody thought that CROSS has been done and dusted. Still, I keep getting calls from my medical oncologist, hey, this patient is not fit for FLOT. I mean, we have gladly handed over all the adeno-CAs, be it CWATs 1, 2, or 3. 3 is definitely going to be treated like stomach. We still keep getting because you cannot fit all patients under one particular umbrella. So that is what I'm trying to tell. So some patients, I think you don't have to break the rules. You can slightly bend your treatment options, and based on the multidisciplinary setting, you can probably offer them CTRT. It's been tested and age-old technique where you have 75% of adenocarcinoma still in that cross cohort. You can still do that. There is nothing wrong. especially elderly patients who are having issues. Most of the patients who come to Hyderabad, especially in the center where I work, come from a lot of peripheral centers. So they're usually the issue is they try to take one cycle here and the rest of the cycles they want to take it there. So we keep getting calls telling that the patients are having severe toxicity issues, a lot of other tolerance issues and other things. So we don't have real trained personnel, especially in the peripheral settings in tier 2 and tier 3 cities. So that will be a major problem that I would say. Radiation is still there, but not for all patients. Based on the multidisciplinary setting, we can have a discussion about that. So thank you so much for your patient hearing. I'll be happy to take any questions if you have.
Thank you, Dr. Sujana Priya. Good discussion on esopic as well. Actually, thank you for bringing that into this discussion. We'll discuss the trial or the questions after everybody gives their chance. Over to you, Dr. Madhu.
Okay, thank you, team CSO and Aju for giving this opportunity because I know that there's a concept called CSO and there's a huge amount of activity going on over there. But I have never been able to come in direct, and I have never been directly involved with any of the activities of CSO. So, but I think now onwards I will be actively getting involved in activities of CSO because I work in a center like Regional Cancer Center where about 90% of patients do not afford any of the treatments that come at a higher cost. So the concept of CSO, the philosophy of CSO applies much more to my center and the patients I take care of. So I've been asked to give a surgeon's perspective on this MATTERHORN trial, and I just specifically asked to be a bit critical if possible. So some of the points that I would be highlighting would be ones that have already been covered over there. So like as a surgeon, I'm happy if I get a patient to operate without progression of the disease during the neoadjuvant or the perioperative chemo or immunotherapy period. And if you look at it that way, about 90 to 95% of the patients who were initiated on any form of perioperative care, the control versus the experimental arm, at last ended up getting operated. So there was not much of a progression, but still, I have a bit of concern regarding the fact that the nature of surgery, the standardization of surgery, etc., has not been brought out either in the primary article or in the supplementary data. Because patients have been drawn from different parts of the world, and we know that there's a huge difference between the quality of surgery from one center to other, especially east versus west, we know that. So this is especially OG junction is one area where there are different types of surgeries we can offer. For example, if you have a type 1 or a type 2 kind of OG junction tumor, we may go for a surgery like Ivor-Lewis procedure or a McKeown surgery, which is a completely different ball game than the kind of surgery you offer for a type 3 lesion where you go for total gastrectomy. So the kind of surgery that has been offered for each of these subtypes of disease has not been properly brought out either in the primary article or in the supplementary article, which I would allow to have it because the extent of nodal changes and it can have an impact on the outcomes of surgery. Again, as highlighted by some of the speakers, most of the time, at least in locally advanced OG junction tumors, we prefer to have a DLAB to rule out peritoneal disease prior to embarking on any form of neoadjuvant or radical form of therapy, which has not been done in this study. As I said, extent of nodal resection, whether it isn't confined to abdominal part or whether some part of the mediastinal nodes were dissected, especially in type 1 and type 2 tumors where it becomes a major component of a radical surgery has been done, it's not brought out. So nodal yield or extent of nodal dissection has not been brought out. So as far as surgeon is concerned, I'm happy that R0 resection has been equal in both the arms, but still I would love to have some more data on the kind of surgery offered, especially for type 1 and type 2 tumors, because we have lessons from the intergroup trial and the MAGIC trial where we know that the non-standardization of surgery can ultimately lead on to the adjuvant or the neoadjuvant compensating for the bad surgery. So here the surgical standards have been good, the outcomes have been good, but still as a surgeon, I would allow to have some more idea. That's one concern. Again, as some of the speakers brought out, I went through the article and the trial sponsors was AstraZeneca, obviously. But this is a common thing, I think, because they're not only that they supply the drug, they also collaborate with the steering committee on the trial design, collecting the data, analysis of the data, and interpretation of the data as well. So I don't know whether there was this can be acceptable, but when I look into other trials of other, for example, the attraction trial or the checkmate trial, the same thing happens over there also. So is it a good practice for the trial sponsor to get involved in the interpretation, design, and the trial results? That is something which, as people belong to the Common Sense Oncology group, we should discuss in detail. Sponsoring the drug is okay, but getting involved in the interpretation and analysis of the data, I think it's taking it too a bit far, I think. But this is common in most of the trials, I believe, not specific for this particular trial. Again, as the Common Sense Oncology guidelines lay down, drafting the manuscript by the writer or somebody contract with the writer should be discouraged, which is not seen in this publication. Again, as has been, again, the PCR. Again, we know from the ESOPEC trial itself, like Sujana was trying to highlight, ESOPEC had more of PCRs in the chemo RT arm, I mean the cross arm, but that did not translate into betterment of the survival data. So PCR, whether it's actually translates into survival data here, of course, EFS has been improved, but well, in the longer follow-up, whether it will translate into betterment of the overall survival, we don't have much of evidence as far as esophagus is concerned, OG junction adenocarcinoma is concerned. So I'm a bit concerned about that. Because if you look at the keynote trial, 585 trial, again, perioperative immunotherapy, pembrolizumab was used in this particular trial. I do agree that the chemo arm was a bit inferior. It was not flawed. It was 5-FU cisplatin, I believe. But if you look at the PCR, the same quantum of PCR was attained in that trial also, 10 to 11% benefit or improvement in PCR by adding immunotherapy. But that improvement, at least in that particular trial, did not translate into overall survival. So 10 to 11% of improvement in this trial is translating into PCA, into EFS benefit. So whether it will actually stand the test of time is something we have to look into. Again, it's not a good thing to compare trials, but if you look at MATTERHORN, Keynote 585, which was a negative trial, perioperative pembro, and the ATTRACTION trial, which is an adjuvant immunotherapy trial, nivolumab trial, I believe. 3-year rejection, EFS is almost better than or as good as the MATTERHORN trial. So the MATTERHORN says 2-year EFS is 67 versus 58%, tilting the slide in favor of immunotherapy. But the ATTRACTION trial, which was a primary surgery with standardization of surgery with D2 dissection, especially coming from China, Japan, and Taiwan, the East, who are known for standardization of surgery, they went ahead with primary surgery and then gave adjuvant S1 plus nivolumab. And 3-year EFS is 68 versus 65%. So how does that compare with the perioperative immunotherapy? So if I have a patient who I can operate upfront, have a better idea regarding the T status, better idea regarding the N status, why not go for that? So that's the question. So where will you place it? Now, do you give perioperative immunotherapy or adjuvant immunotherapy after standard surgery as far as ATTRACTION trial is concerned? So the last question I have to my mind is that whenever we sit in our tumor board, we look at patients who have been given 4 cycles of FLOT, and then they come back after surgery, the response has not been good enough. So what do we do for that? Now the standard is to continue the FLOT itself. So in this particular trial, the MATTERHORN trial, the 2 cycles of immunotherapy has brought about the 10 to 11% improvement in PCR. So do we really need to continue them on immunotherapy for another 15 more or 12 more cycles or complete 1 year? Or are the benefit already there? And other question is, the patients who do not attain PCR, is there any point in continuing the same immunotherapy which was not able to attain the PCR? So escalation or de-escalation based on the PCR or the response to the perioperative therapy has not been addressed. So if we can come down on that and reduce the duration of immunotherapy, the cost factor can be addressed in a better way. So those patients who attain a PCR, and if the PCR is responsible for the improvement in EFS, then why should we again give the same drug continuously? And on the other side, if the PCR is not attained, what the point in giving the same drug again in the postoperative period? Do we need to change the schedule of drugs so the patient can benefit in something like that? So these are some of the points that, as a surgeon, I would like to. Some of the points were surgical, some of the points were beyond what a surgeon should be thinking about. But still, these are the concerns I had. So again, thank you so much, Aju and team CSO, for giving this opportunity and allowing me to look at from a surgeon's perspective. Thank you so much.
Thank you to all 4 of our faculty. Actually, I think we've got a discussion that can give ASCO and ESMO a run for their money. It was terrific from all the 4 faculty here. Thank you for keeping it succinct and to the point, and brought out a lot of valid points which I have not heard before as well. Some of the comments that Dr. Madhu made is very relevant. In some of these trials, it's only a couple of events that actually tilt the survival, the data. And if the surgery is not standardized, then the outcomes can be different. And the whole result could be actually skewed to either one place. I'll open the floor for any questions or comments while we wait. If there is anybody who wants to unmute and speak, please go ahead. Another question that I had in mind was again something that all three of you brought up. I think that was about de-escalation. Do these patients actually need all extended duration of immunotherapy? To Dr. Madhu's comment about attraction trial having better outcomes, probably the quality of surgery from is really good, that part. But I'm also always wondering what is the role of preoperative immunotherapy? There are a lot of studies that shows that while the tumor is in situ in place, immunotherapy is very effective and probably adjuvant has very little role. So maybe in future, some trial from India hopefully may come up that investigates. My only hope is India, and that would be investigating neoadjuvant versus no immunotherapy followed by no adjuvant therapy. I don't know if that's even a possibility. But my guess is a little bit of immunotherapy is sufficient, if at all. Optimal surgery is very important. A multidisciplinary discussion is very important because this is actually three significant disease specialists have considerable stake in it. All right. Anybody else comments?
Aju, since you brought up the attraction trial, I brought up the attraction trial specifically for one reason to highlight 2 points. One is that the standardization of surgery can have an impact on the outcomes. So we know the kind of surgery the Eastern surgeons do, like the Japanese, Chinese, or they have been doing D2 dissections from 1980s onwards, but the Western guys took around 15 to 20 years and 3 or 4 randomized control trials to prove that D2 should be done. Now they are accepted. So the control arm in the attraction trial has the same outcomes as the intervention arm in the MATTERHORN trial. So that is a point that we should know. So is the standardization, if the standardization can be improved, can the MATTERHORN results be furthermore improved? I'm not against immunotherapy in the perioperative, but if you can standardize surgery, will the result be better in the intervention arm? That's what one point I wanted to say. Thank you. Ramakrishna has raised his hands. He wants to say something.
Dr. Ramakrishna.
Thank you, Dr. Raju. I'm very impressed by all the 4 presentations. I think they have laid threadbare the entire trial. And as you rightly pointed out, I think they would give ASCO or ESMO a run for their money. I just wanted to make one point, which is probably not related to this trial alone, but to one particular principle of the CSO checklist for randomized trials. That is the importance of overall survival over any other surrogate like DFS or EFS. Now, I completely agree that to any human being, living for a longer time is probably of primary importance. But at least from an Indian perspective, we must ask, what is the opportunity cost here? Somebody had, Dr. Pradeep had mentioned about the opportunity cost. So what is the opportunity cost of living longer? What are you giving up on? I have been working in public health setup all my life. And I know that a patient spends whatever resources he has for the first treatment. Once a patient develops a recurrence, he probably has run out of money. He is not going to be willing to spend more money for second-line treatment, third-line treatment, fourth-line treatment. The trials which have shown a difference in the DFS, but no difference in the overall survival, really achieve this improvement in the overall survival by various other forms of treatment once a patient develops a recurrence, which are probably not mentioned in the trial per se. But we know that this improvement in the final improvement, or at least the equivalence of overall survival, is because of the additional line treatments that the patient has. But what we really need to think is, in India, how many patients, not in the private or corporate sector, but the majority of patients who come for treatment in public funded institutions, how many of them would be able to afford the second or third line or even fourth line treatment? My take on this is that the best opportunity you have is to treat the patient in the best possible manner the first time he comes. So if it improves the disease-free survival, I would still be happy because he gets to live longer disease-free, which means he's able to go back to work for a longer period of time. We need to think what is the financial toxicity, what is the time toxicity that a person incurs once he develops a recurrence and he sets out to have second and third line. So while the CSO principle of giving primary importance to overall survival may work well in a Western setup or in a setup where the entire treatment is publicly funded. In a country like India, I am not so sure that we should give up on disease-free survival or event-free survival as a very important outcome measure for the patient. We have not really seen what are the values and preferences of patients in India as far as this is concerned. So I would be very interested in any study that looks at patient preference of what he considers as primary importance, whether it is PFS, DFS, or whether it is overall. Thank you.
Thank you, Dr. Ramosh. An excellent point. Very valid question. Again, this shows how much all of our discussions has to be culturally sensitive and contextualized. Manju, you have a quick comment to that or a question?
I just, wanted to very nicely put, Ram, that, we have to be contextual. But what we are saying is, in India, that we don't have second line options. Most of the patients wouldn't really go for second line therapy once the disease comes back. So in that case, the DFS or PFS or EFS should be a surrogate of OS, right? Meaning it should be as good or as bad as an OS in that situation. But unfortunately, we have never shown, and I think it's incumbent upon us to, before we make that statement that we will go by EFS, it's incumbent upon us to make sure that what we are talking is actually the truth. And for us, EFS, PFS, and DFS is actually surrogate of OS because there are no second line therapies. So I think it's important for all of us who are involved in clinical trials that we showcase this, at least in the large multicentric trial. If we are able to showcase that these are good surrogates, I think then we go ahead, because the whole principle is that we may not wait for OS data to come in for diseases which have a very long-term survival. But for others, I think it's good to have OS as the endpoint. And for all others, we should have, an endpoint which is surrogate of OS. So I think it's a very good thing that we can look at our trial data and prove that this is what the case is. And then, of course, we'll have all the reasons to say that, DFS, EFS is as meaningful as OS in these disease settings.
I think we have just crossed the time. We will close. Oh, Madhu, please go ahead.
It's not a comment. I wanted to ask my colleagues. In this particular trial, the compliance to adjuvant therapy was about 60%. So is it okay in a trial setting to have a compliance of 60%, or in real-time practice? At least in my center, I think it's a bit more higher than 60% compliance to adjuvant therapy. Probably the Malayali population are more competent, or they are more happy to take the treatment, or they are more compliant to the treatment, or the health conditions are a bit more better. But I think in our situation, the compliance to the adjuvant part of treatment is much more than 60%. But here I find that in the trial setting, it's just 60%. Are my medical oncologists okay with that, or any comments on that?
I am also completely surprised by that because in our practice we see greater compliance. Maybe are we picking the right patient for the right kind of therapy? But clinical trial patients are reportedly better. So this is a mystery. Yeah.
Like it has been mentioned, almost 75% of the patients are PS0. If you look at the baseline characteristics, a good performance patient.
Good performance. Still, they were not able to complete.
Yeah.
The reason for a dropout might have been different. Like the patient would have opted the ones who achieved like PCR, or maybe due to other reasons they might have dropped out. In our practice also, we are very selective in whom to offer float. And the ones whom we offer float generally take the whole float.
Yeah, I
Well, thank you. That was an excellent discussion. I think one thing that a common thread with all the 4 faculty and the comments has been that the conclusion of the investigator, the sponsored trial is not locked and sealed. It has to be contextual. It has to be culturally sensitive, cost sensitive, and some more data needs to come up to help us figure out the magnitude of benefit. And there are more questions regarding the idea itself of immunotherapy being added to this thing. So it is not as easy as the manuscript authors conclude. We have identified several areas of investigation, areas of debate, discussion, but definitely in the right setting, after much discussion with the patient and the relatives, explaining the various pros and cons, considering the financial capacity, maybe this is something that can be considered. Thank you for an excellent discussion. We look forward to guideline updates from across the world to see how different organizations and countries will update their guidelines after discussion among themselves. But from the CSO perspective, I think this trial is definitely not sealed and locked. We do have several questions that will need to be answered. This inaugural webinar has been amazing in terms of quality. And I think that is something that we want to focus on. Quality of content is more important than the quantity of the people who attend. This will be available on YouTube at some point of time, and hopefully more will be able to listen to this and observe. I've searched on YouTube for similar discussions from across the world, never found any. So this would probably be our contribution to the rest of the world, a good discussion. Thank you, everyone.